Okay, folks. So we'll get going here. We might have a couple more stragglers wander in just as we go. I think you guys all know me. My name is Nick. I'm a provincial staff officer with St. John here in British Columbia, based in Victoria. Tonight we are joined by Dr. Nav Chima. He's a divisional medical officer with Division 176. He is currently based out of, I believe, at a Sunnybrook Hospital in Ontario for a year or two. And he's going to be giving us a talk tonight on the spine, structure, function, and trauma. And I'm going to let Nav do the rest of his introduction himself in a moment. As we usually do, we're going to ask everyone to keep themselves muted and keep your cameras off throughout the presentation tonight. If you inadvertently turn your camera or your microphone on, myself or one of the other facilitators will probably just turn it off for you. The reason for that is as we're recording this and posting everything to YouTube later, it can be a little bit distracting to have other people chiming in. If you do have any questions for Nav, please stick them into the group chat. What we'll do is, if this works for you, now we didn't have a chance to talk about this, but we'll sort of curate the questions to be delivered whenever you feel like you're ready for an interruption. Just let us know. We can catch up with any questions that have been put in there. And with that, I'm going to turn myself off here and turn you guys over to Dr. Chima.
Thanks, Nick. Hi, everyone. Great to be back. It's turning into winter here in Ontario, my first Ontario winter, something to behold. I ordered my winter parka, so hopefully keep it nice and warm. But today, we're not talking about winter, we're talking about spine, structure, function, and trauma. I've pared this down from my original talk, so maybe there might be a part 2 coming out in the future that's going to go into a bit more advanced things, but this is going to lay the foundation and the groundwork for basic understanding a lot more about kind of the anatomy and function of the spine, how it works and things to understand. And then we're going to focus specifically on spinal cord injuries in the setting of trauma, and focusing in on how do injuries occur, and then some pre-hospital care tips for it as well. So we'll just get going. I'll pause at regular intervals to look at the chat for questions. And yeah, here we go. So we're going to start off with some anatomy here. So when we talk about the spine, it falls into the nervous system. Nervous system has 2 different branches: the central nervous system, which is the brain and the spinal cord, and the peripheral nervous system, which involves peripheral nerves, which we can call the somatic system. So those are all the nerves that go in to the skin for sensation, and muscle groups for voluntary muscle movement. And then we also have the visceral nervous system, which is all the parts of the peripheral nervous system that control components that we don't have direct control over. And largely this is comprised of what we call the autonomic nervous system, which is divided into our sympathetic and parasympathetic components. And this is, you also think of this as our flight or fight response. That's our sympathetic nervous system, and the rest and digest response, which is our parasympathetic nervous system. And these are working in the background under not really any direct control, basically keeping everything in homeostasis and balancing out the needs of the body. Now, we're not talking about any of those parts, we're talking about the spinal cord specifically, but I just want to put in a perspective of where the spinal cord actually falls in relation to everything else. Now, we couldn't talk about the spinal cord without talking about the thing that protects it the most, the spine. So we're going to start off there. So human spinal column is composed of 33 vertebrae. We have 7 in the cervical area, 12 in the thoracic, 5 in the lumbar, and then our sacrum and coccyx are fused into essentially one piece. The sacrum being the largest part and the coccyx being the smaller portion at the bottom. And between each vertebrae, there's an intervertebral disc, which is like a cushioning pad essentially that keeps everything mobile and gives it some cushioning and shock absorption in a way, and allows for us to actually have this wonderful thing that moves and protects our spine. Now, all of our vertebrae are actually different shapes depending on where they are in the actual column. You'll notice that further up in the cervical portion, we actually have a smaller vertebral body. That's kind of the more weight suspension portion of it. And then as you go further down, that vertebral body gets bigger because it's going to be carrying more weight in the lumbar area. Now, when you want to feel and see where someone's spinal levels are in terms of landmarks for the bony landmarks, there's actually some things you can use to figure out kind of what level you're at if you're palpating someone's back. If you feel on the back of your neck, whatever the most prominent point is right at the back of your neck at your shoulder level, that's either going to be C7 or T1, because that's usually the one that has the longest spinous process. We'll talk about what that is in a little bit. If you feel the tips of the scapula, so if you have someone at home, someone nearby, and you feel the lower tips of the scapula, that's your shoulder blades, that kind of intersects with the T7 level. The lowest rib, if you follow that up the back, will join up to the T12. And you feel the very tops of those at the more towards the back, and you line between the two, L4, 5 lumbar area. So that kind of gives you an idea of what level you're at. If you have like an injury there or somebody's having pain in that area, can help you kind of determine where you are. I've just got a little remark saying that my connection's unstable because I'm not actually going from home. So I'm just going to turn my video off for a second, just see if that speeds up the connection. All right, moving on. So this just kind of gives you a sense of where they are in the rest of the body. And you can see that the shapes get bigger, and actually the size gets bigger also as you move down the column. Noticing here that, just make sure my mouse is actually on. Noticing here that the cervical discs are much smaller, thoracic discs are a little bit bigger, and the lumbar are really big because they have to accommodate all the weight of the body. All the thoracic vertebrae are ones that support the rib cage, and those are the ones that have all the ribs from T1 all the way to T12, corresponding to rib 1 to rib 12. Then our sacrum and coccyx, which is fused in with the pelvis at the bottom. Now, when we actually talk about the vertebra, each vertebra has specific parts to it. And just to orient you a little bit as well, make sure draw function. Here we go. So this is the back here. So this is the back. Ooh, okay. This did not work as much as I wanted. All right, that's the back there. And then the front is going to be up here. This is the front of this picture. Okay, some orientation. So the vertebral body, which is the largest portion of the vertebrae, at least for the lumbar and the thoracic ones, that is basically the weight suspending portion of the vertebra. And then you have two pedicles that stick out for that and join with the laminae. And the laminae form together from the spinous process. That's that part that you're feeling on the back of your neck when you actually run your hand down your back. Those are those little bumps that you feel are each one of the spinous processes coming along. And then laterally, we have the transverse processes that are kind of like stabilizers that interact with all the muscles. And the last bit to talk about is these bits here, these articular processes or facet areas. And these are what interlock with all the levels above and below. And it's this complex interlocking of joints that actually allow movement, structure, and function to occur. And where's the spinal cord, you ask? Well, the spinal cord is going to be in this area right here. It's protected right in the center between all these components and housed in a nice little portion of the spinal canal in the center. The intervertebral disc is what sits in between all of these and forms that cushioning pad that we talked about here. Now, this is what all the components of the vertebrae have, except for the very first cervical vertebra, C1. And the reason for that has to do with how it interacts with the skull and actually holds the skull on top of the spine. And it's, let me just clear these annotations real quick. Clear. There we go. And it's actually very interesting. So C1 is called the Atlas and C2 is the axis. And if you think back to your Greek mythology, Atlas was the one who held the world above him and spins around the axis. And that's kind of what happens here. You can see the C1 is actually more of a round shape. And this interlocks very nicely with the skull and holds it on top. And then this sits on top of the axis, which is C2, which has a large portion called the dens, which sticks up. And this kind of affixes everything in a nice solid portion, allows rotation to occur as well as lateral movement. And these are all held in place by various ligaments. And this is important because the dens, this bony thing here, is something that can break in a very high fracture. And that's a very dangerous fracture that we'll talk about a little bit later. But just so you know, the shape of the first cervical vertebrae is different and it has to do with this complex interlocking that occurs between the spinal column and the skull. Now, moving on, when we actually look at from the bony components, we're going to be looking at the ligaments, because it's not just the bones. We have a whole bunch of ligaments that actually help stabilize the spine. And there's 5 major ones. At the very back, you have the supraspinous ligament. And then in between each one of the spinous processes, we have the interspinous ligament. And this kind of holds everything together from the back portion. Running along the vertebral body anteriorly and posteriorly, so at the front of the back, we have the anterior and the posterior longitudinal ligament. And then right in between, on the other side of that, in the spinal column, we have the ligament of flavum, which is a very thick ligament that holds a lot of components together in the posterior column. So all these ligaments are helping to keep all the vertebrae intact and prevent them from moving around too much, but still allow enough flexibility that we can bend over, rotate, flex, and do all the movements that you can with your back. Now, I was going to talk about back muscles, but suffice it to say, there are a lot of them, and they don't really play into a lot of what we're talking about in spinal cord injuries for what we have to know for our pre-hospital care. Maybe if I'd come back and do that advanced talk later on, we can talk a little bit about back muscles and some of the things about low back pain, mechanical back pain that we should all be trying to prevent, but I'm just gonna skip over that for now. Now, talk about the spinal column. Let's talk about the actual cord itself. So the cord runs from the brainstem all the way to the bottom, which is the conus, but it's interesting to note that the spinal cord itself actually ends at L1, L2. So that's basically kind of in your mid to low back. And after that, the nerve roots leave the spinal cord and continue down the spinal column in that little hole we talked about as the cauda equina, which means horse's tail, because that's what it looks like when you open up the spinal column at that level. But the actual cord itself is basically a continuation of the brainstem running all the way down to the very bottom. It's called the conus medullaris, which in most people ends around there, but can end anywhere between T12 and L3. And at each level, there's a pair of spinal nerves that exit out through little holes in the side of the column, and these become the main spinal nerves that then leave and at different levels will innervate muscles and sensory organs. Now, there's 31 pairs, but the naming is actually quite interesting. And the reason for that is because there are 7 cervical vertebrae, but 8 cervical nerves. And above C7, the nerve associated with the level exits above the vertebral body, but below C7, it exits below the vertebral body. And the C8 nerve exits between C7 and T1. So that means that when you're looking at different levels and you're saying like, okay, somebody has a, let's say an L3 fracture, the L3 nerve is exiting below that vertebral body. Whereas when you go up to a cervical level, if somebody has a C3 fracture, the C3 nerve is actually exiting above the body. Now, as I said before, there's 31 pairs of spinal nerves, broken down as such. And in each one, what you have is these little holes in the side of the vertebral body, and these are little foramen. And what happens is that you have a ventral root and a dorsal root. And this corresponds a little bit essentially to motor function and sensory function. And we actually have the sensory portion following the dorsal root ganglion, which is the actual where all the cell bodies reside for that level. And as they exit, they'll then go off and branch and form different parts of the different nerves that will innervate muscle, skin, sensory organs, etc. The other thing to note is that at the very beginning, when I was talking about the sympathetic nervous system, there's certain levels that will actually give off sympathetic nuclei. And this is part of this main portion of the sympathetic nervous system that controls a lot of the sympathetic function of the body. And these kind of lie adjacent to the spine in levels from T1 to T12. Maybe a little bit into lumbar as well, but those are the primary levels there. And they'll become important later on when we talk about some of the manifestations of spinal cord injury. But for now, just remember that there's 31 pairs of spinal nerves. There's an anterior root and a posterior root, and those will be encased in little nerve sheets before they go off and branch into the rest of the body. Now, the actual spinal cord itself, so that's the central bit that we're talking about here. There's various nerves running up and down the entire column. And this is one of the portions that I cut out because we're getting really deep into neuroanatomy here. But running up and down, different parts of the cord control different functions, specifically in terms of different sensory and motor functions. And generally, and this is a very big generalization, is that a lot of sensation is going to be in the midline in the back, as well as a little bit in the front. And motor is generally going to be in the front and to the sides. But as you can see from the picture on the right, where blue is sensory and red is motor, that isn't always the case. There are many different, what we call tracts, that run up and down the spinal column. And they are symmetric, but they control various different functions. The three main ones that we focus on are the dorsal column, the corticospinal tract, and the spinothalamic tract. The spinothalamic tract is it's a sensory tract, and it's responsible for sending pain and temperature signals from the periphery, so from the hands, feet, other parts of the body, all the way up to the brain. The dorsal column is responsible for sending sensation about vibration and proprioception. Proprioception is understanding where your limbs are in relation to space, so where they are in relation to each other, from the periphery up to the brain. And then the corticospinal tract is a major muscle tract, and it's reliable from sending motor functions from the brain down to the periphery. Those are the three big ones that we talk about, and that's important when we're thinking about testing various levels, especially when you're thinking about testing different injuries. Because if somebody is able to sense pain and temperature at a level, but is unable to test or sense vibration proprioception, then that means that their injury would be more confined to the front of the cord rather than the back of the cord. And that's important to know for diagnosing certain injuries. But I'm just going to leave that for there for the moment, and I'm going to just stop there for a quick break. I'm going to check the chat and see if there's any questions. I don't see any questions. If anyone's typing
I had
up.
a couple I wouldn't mind just throwing at you really fast now. I just wasn't putting them in the group chat there. But
sure, go ahead.
Something I've heard often from lecturers is that the cord, the spinal cord, is part of the brain or part of the CNS. Could you maybe just talk really fast about the relationship between, like, say, the upper cord versus the brainstem and the actual brain itself?
Yeah.
The other question, no, I'll leave that. I think the other two are, I suspect you might answer later on, so I'll just leave it at that.
Okay, I hope so. Essentially, it's a pure continuation. So if you were to magically, like, oh, not sorry, I was gonna say a relation to a movie, but so if you were to magically remove everything in someone except for the nerves, and you looked at the spinal cord running off the brainstem, you would not be able to tell where one started and where one stopped. It would basically look like a continuation. If you were to look at a microscopic level, so like a pathology slide and sliced up on the way, then you'd be able to tell different structures moving up and seeing, okay, here's the part where it starts, here's where it ends. And there are parts of the brainstem and hindbrain specifically that will look distinctly different, but for the most part, they, in terms of where that relates to the brain.
You cut out there for about 10 seconds. Could you maybe go back about 15 seconds?
Yeah, for sure. Can you hear me okay now?
Yes, Ken.
Okay, so if you just looked purely at the brainstem, so you removed all the other stuff, you removed all the bones, you removed all the muscles surrounding it, all the ligaments, all that stuff, the brainstem and the cord would look synonymous. They kind of run into each other. The brainstem itself does have various changes in it, especially when you run from the brainstem, from the hindbrain, medulla oblongata, and going up into the brainstem, into the thalamus, hypothalamus, midbrain. But for the most part, when you looked at whatever we call the bottom of the brainstem and the top of the spinal cord, they join together and they're basically continuations of the other. Pathologically, like if you look at them under a microscope, they will look different in different areas, but functionally they are exactly the same. In terms of the actual brain itself, like the actual cerebellum, that's like that's complex developmental, but I mean, it's essentially you have the folding that occurs over from the top of the brainstem, folds into cerebrum, from what I can remember from my embryology days. But that happens at like a complex early developmental embryological level.
Fantastic. That was a fantastic answer, Nav. Thank you.
No, I hope so. That's going way back to my embryology, which is not my strong suit, but yeah, I'm glad I can help out with that. Okay, I will check the chat. No questions. Okay, I'm going to keep going here. So we're going to talk a little bit about function of the spinal cord, which basis, it's to relay signals from the body up to the brain and to allow motor signals from the brain to be relayed to the rest of the body, as well as other signals that are necessary for daily functioning. But I kind of want to talk a little bit about functioning in relation to how we test for functioning. And whenever there's a spinal cord injury, regardless of where you are, eventually in the hospital, somebody's going to get this sheet filled out. And this is the International Standard for Neurological Classification of Spinal Cord Injury, previously, or also known as the ASIA classification, American Spinal Cord Injury Association. And this is basically the complete spine neurological exam right here. And so remember when I was talking about those 3 tracts, spinothalamic, dorsal column, and our corticospinal tract. Those are the 3 tracts that we're primarily testing on this sheet, because this will help us determine what level our injury is and what areas of the spinal cord are injured. And so if you look at this sheet, there's 3 major things that we're testing here. We're testing sensation to both light touch, which is similar to, carried by the same nerves as vibration proprioception. And we're testing it to pinprick, which we would consider pain sensation. So those are those 2 sensory paths we talked about. And then if you look on the motor function, we're testing motor components. Now, there are very few easily testable motors that we can test between T2 and L1. And that's why you see this big gap in the middle. But essentially, we test from C5 to T1, and we test from L2 to S1. And this is what happens. So when somebody comes in with a spinal cord injury or suspected spinal cord injury, these get tested, and we can determine the level as well as the area of the spinal cord that is that has damage to it or has injury to it. Now, there's also various different scoring things at the bottom that you don't have to know. But what is key to know is that when we test these areas, these little dots that are all along the body here, those dots represent where it's supposed to be actually tested. And this is actually kind of nice, because if you're ever having to do a neurological exam in the field and you're trying to say like, oh, like someone saying, well, I don't feel any sensation below my nipple line. Well, you'll know that, hey, nipple line is T4. That's common reference point that we use. Xiphisternum, so your xiphoid at the bottom of your rib cage, that's T6. Your belly button is T10. You can use your kneecaps are L3. And so these are kind of helpful landmarks that you can use, especially for a quick neurological exam if you don't have time to do this, but these are things that we'll do in the hospital, especially when we're determining levels. And then ditto for muscle movements can help you determine what level you're at. And again, this is kind of beyond what would be needed for St. John duty in determining levels, but I think it's kind of nice to get a sensation, or get an idea of if you have somebody with an injury, especially a bad spinal cord injury, you can determine pretty quickly where that injury may be, and can be helpful in treatment later on. So when we're actually grading muscle function, oops, sorry, I'm gonna go back here. We actually give it a score. So it's not just is the muscle working, but is the muscle actually working sufficiently? And when we do this in hospital, we test to see how well that muscle is going. A 5 is a normal exam, so you're totally strong, you're able to move fully, and then basically that strength diminishes, whether it's against gravity, not against gravity, and versus just some muscle contraction but no movement. And that has to do with the degree of injury, because the more injured that nerve segment might be or that level might be, the worse your muscle grading is going to be. Sensory is basically just, is it there, is it altered, or is it absent? Now, those main muscle groups that are tested are shown in the table on the left here, but there are alternate muscle groups. And this is why, you know, you don't necessarily want to be doing this in the field, because unless you've had multiple experiences and teaching on what specific movements are which muscle, then it might be hard to know, because as you can see, different joints, depending on how you move them, will target different nerve roots, and you need to be able to do the full exam. But this at least helps give you an idea, especially when you encounter one of these patients in the field, what level it is and what needs to be done. There are some great videos on YouTube showing spinal motor exams, spinal sensation exams that, if you are interested, are great to watch, and will show you specific movements and how to do them and how to test for certain levels. And some people may ask, well, why is it so important to determine the level of injury? Well, it has a lot of importance later on, but the big one that we worry about, especially for high spinal cord injuries, is an injury to C3, 4, or 5. And there's kind of a famous saying in med school, in all medical fields really, C3, 4, 5 keeps the diaphragm alive. And that's because the phrenic nerve, which is the major nerve that controls innervation to the diaphragm, comes off at cervical levels 3, 4, and 5. This is kind of one of the main motor nerves that's needed for proper breathing, voluntary breathings, and usually liberation from a ventilator. And so this is why we worry about high spinal cord injuries, specifically C3, 4, or 5, because injuries above that level will have significant impairment to ventilatory function. And these patients will often have to be intubated and placed on a ventilator sooner rather than later because they won't be able to sustain normal lung function. But it's not just C3 or 4 or 5 that keeps the diaphragm alive and the patient alive, but other high spinal cord injuries, because if you think back to our respiratory lecture from a while ago, there are so many accessory muscles that are involved in breathing, and not only breathing, but also coughing and being able to clear secretions. And this is one of the dangers that can occur with high spinal cord injuries. Is you may have normal lung function because you can breathe normally with your diaphragm, but if you're unable to cough and clear secretions, you're very prone to developing a pneumonia or collapsed lung, which can then lead to scarring and make it even worse for lung function later on. So that's one of the reasons that we really worry about the level of the injury, especially for high injuries. The other reason that we worry about high injuries has to do with cardiac function. And so remember back to a few slides ago where I was talking about the sympathetic nervous system and that sympathetic chain that runs along the thoracic vertebrae from T1 all the way down to T12, L2-ish area. Well, that sympathetic chain is in balance with the parasympathetic nervous system, which is our rest and digest. And those two are normally kept in homeostasis. So heart rate goes up a little bit, the parasympathetic nervous system will tone it back down, heart rate goes down, the sympathetic nervous system will speed it back up. And this is how we kind of adapt to our daily functioning. But with a thoracic level spinal cord injury, especially when the damages the sympathetic chain, you lose some of that sympathetic innervation. And as you start to go up the chain, that balance between the sympathetic and the parasympathetic nervous system starts to wane and goes more in favor of the parasympathetic nervous system. And if you have a high enough injury, you may actually knock off what are called the cardiac accelerator fibers, which are somewhere around the T1 to T4 range. And these are necessary for allowing the heart to speed up, especially under certain circumstances, and counteract a lot of the changes that might be occurring in the body. And so when you have an injury, usually above T6, you start worrying that now your parasympathetic nervous system is going to go unbalanced. It's going to become into overdrive, so to speak. And this can cause your heart rate to slow down, your blood vessels to dilate, and your blood pressure to drop. And this can be really bad. And this is why a lot of high thoracic spinal cord patients, when they come into hospital, we'll actually put them on endogenous, so supplement their sympathetic nervous system by putting them on an epinephrine or norepinephrine IV drip until the body kind of adapts and takes over via other mechanisms. And so that's why determining the level of injury, not only for function and determining prognosis, but also for looking for some of these downstream sequelae of spinal cord injury. That's right. That's why determining the level of injury is so important. The one other thing I'll say before we go on to types of injuries is that, and we'll get into this a little bit when we talk about types of injuries, but the level of spinal cord injury may change depending on the progression of the injury. And I'll leave that for when we actually talk about injuries there. So I'm just going to check the chat for questions. No questions. Moving on. So let's talk about types of injuries now. So there's the same group that came up with our classification for how we do the testing also came up with how we determine the type of injury that the patient has. And they've categorized it into 5 different categories. We have 1 type of complete injury, 3 types of incomplete injury, and basically normal exams, so no injury, no disturbance in sensory or motor function despite a possible injury seen on imaging or visually. Type A or category A ASIA classification is essentially no motor or sensory function below the level. And it can be also called flaccid paralysis. So that's basically complete spinal cord injury. And then B, C, and D are different levels of spinal cord injury. They're incomplete injuries. So B has sensation but no motor function. C has motor function preserved to some level in half muscle groups, and then D has motor function preserved but to a stronger level than the C level. And then E is essentially normal at that point. And so when we do this this graph here, we can basically come up with that determination of the time. And this may change depending on how the injury progresses and what other interventions we do to the patient. And this, and as I said before, it's never a complete picture and things may change. So if you have a complete cord injury at high level, you can have a complete injury or an incomplete injury depending on what nerves and what segments of the spinal cord are affected. But there are also some other patterns that can occur, and I won't get too much into this, but it has to do with how the cord is injured and where the injury in the cord is. So for example, you can have an anterior cord syndrome or posterior cord syndrome, as you can see from the bottom 2 pictures. So if predominantly part of the anterior cord is damaged, then you lose more motor function than sensory function. But if you have just a posterior cord injury, then really you're losing just sensory function and have, for the most part, motor intact. And there's other types of incomplete injury. There's Brown-Séquard, which is a hemicord injury, central cord, which is more, the upper motor is weaker than the lower motor. And these basically just have to do with the type and area of the injury that occurs. So let's talk about trauma specifically, spinal cord trauma. Just gonna check the chat, nothing there, okay. So I want to talk about spinal cord trauma specifically because this is going to be the most common injury that we see, especially out on a St. John ambulance duty or in our paramedic professions. Estimated looking at major trauma patients, 1.5 to 3% of major trauma patients will have some form of spinal cord injury. And I want to be clear with that. That's actually spinal cord injury. There are lots of patients that come to a trauma center that will have injuries to the spinal columns. That's the bony components, the ligamentous components, etc. But their cord is going to be intact. And that in and of itself, and I wish I actually had some numbers on that, but I don't, but colloquially, I would say like 4 to 5 patients in major trauma probably have some form of spinal column injury, just from my own experience, but that's at a major trauma center. All trauma, I can't give numbers, but I'd estimate it's at least about 50%. But 1.5 to 3% of major trauma patients, that's pretty significant. Like that's more than 1 in 50 patients will have a major spinal cord injury. And especially when you tie that into a traumatic head injury, which is up to 1 in 20 patients, we're talking about a pretty significant burden that can occur, especially in terms of burden of injury and lives and productivity loss. So this is an important thing to talk about, especially when you consider half of those injuries involve the C-spines, that high functioning area that can lead to very significant injuries. When we actually look at the etiology and what causes these injuries, motor vehicle collisions and accidents form the vast majority of these injuries, about 30%, 30-40% of presentations, but falls, especially in the elderly, can also contribute to this. Sporting accidents, diving accidents, but other sporting accidents as well. Self-inflicted is higher up, and then we basically swapped with the US for violence and self-inflicted, so we have a higher rate of sports-related and self-inflicted, whereas in the US has higher rates of violent ones, and I got some figures to show for that later. Risk factors for spinal cord injury, sadly being male and young age, alcohol abuse tying into motor vehicle collisions is one of the higher risk factors, but also having pre-existing spinal conditions, especially for elderly and thinking of falls. So having cervical disc disease or spondylosis, having some degree of instability in the spine already, either due to congenital problems, ligament laxity, or bony weakness such as osteoporosis, and then having certain diseases of the spinal column such as rheumatoid arthritis affecting the spine or ankylosing spondylitis. There's actually a good review paper that came out in 2004 from a Canadian group, and it looked at a whole host of countries and predominant cause of spinal cord injuries in those countries. Canada, they broke up into Western and Eastern Canada. They didn't say why Western Canada had more motor vehicle collisions than Eastern Canada, and Eastern Canada had more falls. I don't know, can't speculate on that at all. But when you compare it to the US, for us, motor vehicle collisions and falls for both groups are high. But when we look at our next slide here, we look at violence, you can see that the US has much higher rates than we do here. And then sporting related accidents are higher for us in terms of overall percentage. Now this is, remember, this is percentage of overall numbers, not absolute numbers. So it doesn't mean that we have more sporting related spinal cord injury ones. It's just that of our presenting numbers, sporting ones are a higher group. And then self-inflicted suicide attempts kind of round out the bottom percentage there. When we actually look at the distribution of injuries, especially when we look at paraplegia versus tetraplegia, fairly significant numbers, so almost half are some form of incomplete tetraplegia, which is a high injury, which may mean reliance on a ventilator, reliance for self-care. Complete paraplegia is about 18%, complete tetraplegia is about 12%, so still pretty significant. When we, this comes from American figures, about 50% of patients injured between the ages of 16 and 30, so young age, a lot of like work years and functionality lost there, and 13% of patients with spinal cord injuries have to go to some form of institutionalization or nursing home care just because self-care becomes so difficult. When we actually look at the mechanism of spinal cord injury and injury to the cord, commonly for blunt trauma, we're looking at something that disrupts the actual spinal column that's protecting the cord and leads to secondary injury afterwards. Having an actual frank transection of the cord is actually very rare in blunt trauma. Much more likely in penetrating trauma, but again, that has to be penetrating trauma to the spine. But in terms of blunt trauma, it's usually something else breaking and either causing pressure or a force on the spinal column, or sorry, the spinal cord that will then cause the injury. When we think back to our anatomy and all those different parts I talked about, the bony segments, ligaments, the joints, and the disc, any of these can be disrupted and cause injury to the cord. Now, the back is very unique because when you think of the joints in the body, back is unique in that it can move in essentially any direction. And as such, you can have an injury from any direction of that movement, whether it be flexion, extension, rotation, and compression. There's an amazing picture out there that has all the different movements of the spine and all the different injuries that you can have and all the different kind of fractures and dislocations and tears and everything for it. And for the life of me, I could not find it. So I had to steal this one off of Google, which isn't as good, but gives you an idea. This shows you the different types of injuries that you can have. So flexion injury, where you have the spine bracing forward. Hyperextension, where the spine extends back too much than it should. Compression, which is usually from a fall, where you fall and then the actual vertebral body bursts and compresses the spine. And then some form of rotational injury, so twisting where something shouldn't and causing injury to the spinal cord there. And of course, when you take all those injuries, some of them are really bad and have to be fixed right away because they are what we call unstable. They are at very high risk of creating further injury, but a lot of them are actually fine to just let heal naturally, or at least let heal at a later date, either by operative fixation or external traction. And you can see that the vast majority of them are unstable in this group, but that doesn't mean that the vast majority of injuries are unstable. And it takes some specialty in spine surgery to figure out what's stable and unstable. And even when some of these trauma patients come into the emerge and come up to the OR, I'm always referring to the spine surgeon saying, hey, is this injury stable or unstable? What can I do with the neck? What can I do with the body when we're positioning the patient getting ready for surgery? So this gives you an idea of kind of like the scope of the injuries that we're talking about here. Now, how does the actual spinal cord become injured, and how do we actually get to that injury in the first place? Well, there's two different terms that I want to distinguish first of all, because they get thrown around in the literature a lot and they are very different. So the first is spinal shock. And the funny thing about spinal shock is it's not actually a type of shock in the way that we think about it in terms of like low blood pressure, poor organ perfusion. It's the spinal cord itself going into shock. Sorry, that's actually a better way of describing it, because that makes you think that it has low blood pressure, which it does, but sorry, I'm going to back why. So spinal shock is loss of neurologic function below level of injury. So the spinal cord is just not functioning because of the injury that has occurred to it. And this is usually due to a direct injury, so either direct blow to the spinal column, direct hemorrhage into the cord, transection, or due to secondary injury. So maybe some swelling on the cord causing decreased blood flow to that area, and those nerves aren't functioning well, or disruption to the blood supply or oxygenation to the area, and now those cells aren't really receiving adequate blood flow and adequate nutrition that they need. This leads to essentially flaccid paralysis, so no functioning as well as loss of reflexes, and this usually lasts days to weeks. And this was important because, as I said before, the main purpose of doing our exam is that we're using it to track the progression of the injury. So if somebody comes in with maybe some mild sensory loss initially, but then all of a sudden has more progressive sensory loss, and now we're starting to lose motor function, and that's evident of an evolving spinal cord injury, and one that we may have to intervene on sooner rather than later. But then likewise, when we're looking for recovery, different injuries recover at different rates. And so we can actually track that as we see different levels come up, especially in different locations of the spinal cord. So that's spinal shock. Neurogenic shock, that's more of the kind of shock that we think about when we're thinking of shock in the classic sense, like hemorrhagic shock or obstructive shock. And that's specifically hypotension and bradycardia that can occur because of disruption to that sympathetic chain that occurs. So our heart rate slows down and our blood vessels vasodilate, and we don't get enough perfusion to the rest of the body. This usually resolves just 3 to 5 days after different compensatory mechanisms take over afterwards. Now, when we actually look at the injury to the cord itself, we can break this up into primary injury and secondary injury. Primary injury is what happens right when the cord gets injured. So usually it's due to compression of some kind from something that's burst nearby, or fluid or blood, or pressure on the cord. And as I said before, frank transection or frank hemorrhage in the cord is actually fairly rare in non-penetrating trauma. But what we worry about is the secondary injury that can occur to the cord. And this is usually due from decreased blood flow, decreased oxygen, inflammation in the area, edema that can occur. And this is usually why we have to intervene in addition to making the cord more stable afterwards from an injury. Whether it be to take pressure off the cord, evacuate a clot from the area, improve blood flow to the area, or try to resolve some of the edema that might be developing on the cord. And this is what we target when they get to hospital. So after Nick has gone and picked up our motorcyclists off the side of the road and brought them in, when we bring them in, we're targeting these secondary issues that may occur and making sure they don't occur. So we give them medications to support their blood pressure to make sure that the spinal cord has enough flow to the area. If the patient isn't breathing very well, we might intubate them and put them on a ventilator so that they can breathe better and get enough oxygen to the area. We'll give medications to reduce the inflammation and other ones to reduce the edema around the cord. And if needed, we'll take them to the operating theater and do an intervention to try to relieve some of the pressure on the cord afterward. Usually this secondary injury is in the first couple of days and resolves around day 6 or 9. And that's how long we'll continue some of these therapies to make sure we try and prevent some of the secondary injury from occurring. And really what we're looking at is when I talk about that pressure, that back pressure that's occurring on the cord, the reason that we're focusing so much on the blood pressure is that the actual spinal cord perfusion pressure is going to be equal to our mean arterial pressure, so essentially our blood pressure minus whatever that pressure is. And so if we have bleeding or edema or extra fluid in the intraspinal space that's causing compression on the cord, we want to raise the blood pressure to try and increase our spinal cord perfusion pressure. Now, don't take that to mean that in the field, when you scoop these patients up, you should be trying to raise their blood pressure somehow. That's something that's determined in the hospital when we get there in consultation with a spine surgeon, neurosurgeon, ICU doctor. It really depends on the type of injury that's there. And what we're trying to do is limit what we call the ischemic penumbra, that secondary zone of injury, from getting bigger, to try and limit some of the size of the injury. So our main goal when we have these patients is to prevent secondary injury to the ischemic penumbra and prevent further disruption of tissues. Now, I'm going to pause there for a moment before I talk about spinal immobilization. Any questions there? I see nothing in the chat. Oh, something popped up. So the question is, how precisely are you trying to control the blood pressure in these patients? Good question. So when these patients come to hospital and they deem to have spinal cord injury, where we want to try and improve our spinal cord perfusion pressure, there's two things we can do. We can either decrease the intraspinal pressure, or we can increase the mean arterial pressure, or their blood pressure. So usually, if we're going to try and decrease the intraspinal pressure, it usually involves placing a drain in the spinal column to try and get some of the extra fluid off, or more commonly, it means taking them to the operating room and relieving the pressure. So doing an operation on them, so flipping them on their back, taking off the bony components and evacuating any blood or extra tissue or diseased tissue that might be in that area, and then putting it back together again. In terms of raising the blood pressure, usually this is just done with medications like norepinephrine or epinephrine, or dobutamine even, or milrinone. Those are ones that actually increase cardiac contractility to try and improve the perfusion of the cord. And these are standard medications. We use them in all sorts of conditions like sepsis. For example, we use norepinephrine quite a bit. In cardiac patients, we'll use epinephrine and dobutamine. So these are just different ways we can raise the blood pressure. So those are kind of the two things that we'll do most often. Another question I have here says, I have several friends who have secondary injuries. One has a T4 incomplete, but due to swelling and bleeding is classed as a C5-6. So yeah, so this is one reason why the injury site on imaging may not correlate to the actual level of injury, because sometimes we can't actually see some of the damage that's going on, especially when there might be bleeding or other pressure going on. So somebody could have a T4 frank transection, but because of further bleeding or edema that develops higher up in the cord, their level of injury may be different. That's why doing the exam is so important, in addition to the imaging that we do in the hospital. Okay, so I'm going to talk about spinal immobilization, and initially I was going to go through like some facts and figures about spinal immobilization, but I thought, oh, over Zoom, that can be kind of challenging to show like how to do it and how to do log rolls, and that's something that's better dealt when our pandemic is over and we can get together and be all happy and fun again. So what I want to talk about in spinal immobilization is kind of some facts and some myth busting about it. And I guess I should throw up my big disclaimer here that the things I'm going to talk about here shouldn't replace whatever care guidelines you're using right now. So if you're MFR level and working with St. John, follow the St. John protocol. If you're with your local ambulance brigade, like BC Ambulance or Ontario Paramedics, use whatever that is. If you're a nurse or a doctor or something else, follow whatever you're following. This is just kind of some food for thought to think about. So when we talk about pre-hospital care, especially for spinal cord injuries, really it comes down to basic good trauma care, focusing on A, B, C, D, E. Fine when you can, and working around that as much as possible. And remembering that, as I said, when you have that spinal cord injury, you want to try and prevent that secondary injury from occurring as much as possible. And that secondary injury, one of the key things that'll cause that is hypoxia. So if the patient has other injuries that are preventing them from breathing properly, like they're unconscious, for example, assisting them with their respirations is going to be one of the biggest things you can to preventing further injury from occurring. And it's going to be tricky with somebody holding manual inline stabilization, but focusing on A, B, C, D, E's, and I would almost add in a second E for extrication, getting them out of that area and to a trauma center as fast as possible is going to be the biggest change that they can occur. With the spinal immobilization, we talk about kind of three key components: the cervical collar, some form of barrier to lateral movement of the head, whether it be foam blocks, the rolled towels, the SAM headbed, or the actual headbed TM, and then some form of long board, spinal immobilization board, or scoop stretcher that you have. Now, as I said before, the information presented here does not replace current guidelines set out by St. John Ambulance or your local care organization. Please follow local guidelines and training protocols. Okay. There is an excellent review out there that that you guys should all read by this guy, Salim Razi, on Rebel EM. And he talks specifically about spinal immobilization in trauma patients. And the big point when you look at all these things, so when we're taught like in St. John and ATLS, we taught a lot about spinal immobilization, and basically like almost any trauma patient, yep, C-collar, longboard, strap them and go. And that's very much the case. But it seems like there's been a big shift towards a lot more spinal immobilization of patients that may not need it. And there's been a couple big reviews looking at these, how many patients are we actually immobilizing with a longboard and C-collar and everything else that don't actually need it. And a lot of them don't. But the thing is that we're all worried that if we miss the one that has a spinal injury, and we do something that causes further injury, then that's going to be really bad. And I said this is going to be bad because, as I said before, there's a large number of patients out there with high C-spine injuries or high T-spine injuries that can have a significant burden and loss of life function. So we do want to be very careful with that. But it is interesting to think about some food for thought, especially in terms of what we're actually doing. So there's 2 points I want to bring up about spinal immobilization from this gentleman's article. Definitely go read it yourself. It's a great article. But the first one is that when we're immobilizing these patients with a C-collar and a longboard, are we actually preventing movement of the C-spine? And the answer is probably not as much as we think we are. There was a study that was done where they took healthy volunteers, put them in a rigid collar, and either affixed them to a longboard or a stretcher mattress, and then drove them around in an ambulance at 20 miles per hour. And they measured the amount of movement that occurred with the head with sophisticated lasers. And interestingly, what they found was that there was more movement to the patient who was strapped to a longboard than the patient who was just on a stretcher. Now, what the take-home point of that is that you need to note that this is not a clinical study. These were healthy volunteers, so they weren't splinting to try and hold their injuries. We don't know how much movement was significant. And keeping in mind that the movement they were detecting here was less than 1.5 centimeters, so it wasn't really that much. But if what we're actually trying to do is prevent any movement from that C-spine to that T-spine all the way down to L-spine, then we probably need some sort of better affixment device than what we have out there currently. The other thing I wanted to bring to your attention is that spinal immobilization causes pressure ulcers, especially if you can't get patients off them very quickly. So there's a study that looked at, it was reviewing a whole bunch of papers from 1970 to 2011, and it was looking at spinal immobilization and any relation to pressure ulcers that occurred. And they found 13 studies. And what did they find? They found that pressure ulcers can occur very commonly, especially when patients are left on a longboard for a long time. And the location of these ulcers are usually in places where there's going to be large, heavy point contact between skin and the board, higher up, occiput, chin, clavicle, and shoulders. But also can occur in the sacrum, so on the back of the hips, and the scapulae. And the biggest risk factor for this to occur was when we had was the length of time that that the patient was on a spinal immobilization device. And everything else kind of is a function of that. So high pressure pushing down on it, causing it pain from the device. So if the patient says, "Oh, that's uncomfortable from that." And I remember like way back from my EMR training that, my teacher would say like, if it's not uncomfortable, then it's not tight enough. And in a way that's almost being carried around. But I think we have to be careful in how tight we're actually tying some of these spinal longboards down. ICU admission and high injury score basically just correlates the fact that if you have a high injury score or ICU admission, you're probably gonna be unconscious or on a longboard longer because you're getting there. So what they recommended from this study is that replace whatever board or hard board, longboard they're on whenever it's safe to do so, and replace the rigid collar with a soft collar as soon as it's safe to do so as well, or just clear the C-spine by physical exam and radiographically when possible. Now, again, doesn't oops, sorry. Now again, this is just observational data. It doesn't, it's correlation, not causation, but something to think about, especially when you have patients who are on longboards for a long time. He makes a point in his article there are a number of other things that can be caused from prolonged spinal immobilization, but I'll leave that to you to read afterwards. So because of this, the National Council of EMS Physicians, the American College of Surgeons, Committee on Trauma actually put out a position statement. They said that even though their longboards and rigid immobilization devices are used a lot in trauma patients, their benefits has been largely unproven, as being kind of more colloquial and something that we done before, and we're going to keep doing it because that's all we have right now. But longboards can cause pain. The patient can get agitated when they're strapped to it, and can cause respiratory compromise. If you imagine you're strapping this person around the chest, it might be hard to breathe at the time. And you should be cautious when using it as much as you can, especially if there's benefits that outweigh the risks. And again, I don't want to say stop using, I'm not saying stop using longboards, stop using cervical collars, because they are good devices for what they're built for, which is extrication and transport. And that's what we should be using them for. But learning proper techniques, especially when we're back together in the real world, being able to work in groups and do things face to face, and using them just for that extrication, transport, getting them to the trauma center, and then having someone get them off the board as soon as possible. And we'll do this at our hospitals when they come in. As soon as they come in, we're trying to get them off the board, either clear their spine via physical exam or radiographically as soon as possible, and transition them to a much safer device that won't cause some of these compromises from occurring. And especially when we look at kind of where the future of EMS is going, a lot of places in the States, and I don't know here, maybe Nick can chime in on that afterwards, are working to see if paramedics, first responders may be able to clear a spine or at least limit immobilization, depending on maybe some more liberal uses of mechanisms of injury. And when would you immobilize? Well, it might be necessary if there's major blunt trauma or the patient has an altered level of consciousness, because usually that would imply a high energy mechanism, so high likelihood of secondary injuries, spinal pain or tenderness. If there's an actual neurological complaint, so numbness or motor weakness, definitely to do C-spine precautions at that point. Any anatomic deformity or any high energy mechanism where there's some kind of confabulating issue like drugs or alcohol, a patient can't communicate, or there's distracting injury. But when may we not have to immobilize? Well, normal level of consciousness, no tenderness, no neurological combining, no distraction injury, no intoxication. So again, it's something to think about, but for now, keep following whatever St. John Ambulance tells you to do, or BC Ambulance or Ontario Paramedics, or wherever it is you're working and joining us from. But it's some food for thought. Just so you know, there's two things that we use in the hospital when we're trying to clear a spine. Now, for the most part, when we're clearing a spine, we do both a physical exam as well as a radiographic exam. So you most commonly a CT scan, sometimes an MRI as well. But there are some criteria that were developed to try and rule in or out whether or not we had to do a CT scan in the first place, because CT scan has a lot of radiation and not everyone may need one. So there's two criteria. There's a NEXUS criteria and there's a Canadian C-spine rules. NEXUS criteria, they're both used for cervical spine injuries, but they're kind of used to determine whether or not somebody needs imaging or not, or whether you can just clear it at the bedside. NEXUS is very broad, and you have to be pretty good to get through NEXUS, but Canadian C-spine rules are pretty specific, and you have to be really good to get through Canadian C-spine rules, because one of the first three things you have to ask is the patient more than 65 years old? Was there a dangerous mechanism, which is outlined on the right here, so some kind of major fall from 3 feet, axial load, high speed MVC, motor vehicle struck, etc., or is there any paresthesias? If any of those answer yes, you're just going to image that patient anyway. Keep in mind also that these rules don't apply to non-trauma cases, decreased LOC, unstable vital signs, etc., the whole list there. After you look at that, then you have to actually say, is there any low-risk mechanisms in this injury that would necessitate being safe to do this? And these have to be pretty specific to the patient. If none of those criteria are met, you image the patient. And then lastly is the patient able to rotate their neck by themselves? Doesn't matter if they have pain at that time, just can they do it? If they're able to, then they don't need imaging and you can clear the C-spine. But again, this is what we might do in the hospital under very specific circumstances, not something that we can do in the field yet, unless maybe Nick can chime in now.
Sure, I can
Yes,
comment a little
exactly.
bit now. So a couple of things. I have to be a little bit cautious about how I present this, because we've been given some new guidelines about publicly identifying ourselves by our work roles, and then perhaps being perceived as we're speaking on behalf of the organization. So I'm going to stick to very publicly and I am not speaking on behalf of my employer right now. But speaking in terms of some very, very broad generalizations and fairly public information, we are in BC using NEXUS criteria to evaluate C-spine injury. We are not supposed to be transporting at all on longboards anymore. And we're discouraged unless there's multi-trauma and like sort of clinical indications that we need to have whole body stabilization. We're even moving away from transporting on clamshell stretchers. If someone's a multi-trauma patient and there's multiple displaced limb fractures or something like that, that's maybe one thing. But for someone who's been involved in an MVI, has maybe some midline tenderness, but was able to self-extricate from their vehicle, has no other obvious injuries, we might just be placing a collar on that person and putting them on our stretcher now. And that is backed up. I don't have the resources directly available to me now. It's all backed up by some evidence-based changes in practice. But yeah, in terms of that stuff, we're seeing, and I believe that those trends are mimicked by a number of other EMS agencies around the country and around North America. So, as you sort of described, we're moving away from this old, strap people to the longboard with 20 spider straps and lock them down and let their head flop about while we hold the rest of them steady, and all that was maybe taught. Certainly when I started, that was what we were taught. Is everyone goes on a spine board, and if they tripped and fell and bumped their head, they go on a longboard and all this sort of stuff. And in terms of field evaluation criteria, it really is NEXUS criteria is what we're primarily relying on. I don't know, Nav, if you had any other questions or anything else that you wanted me to clarify at all, or if
No, that's perfect, Nick. Yeah, because I've been, as I said, I've been out of the field for a while. I'm living in my lovely, clean hospital. Well, clean as most part, but lovely hospital where we get patients who are nice and packaged, and we unpackage them and do stuff to them. So it's been a while since I picked someone up from the side of the road, but
yeah. I think it's the ivory
it's
tower of academia, isn't it? Really?
Yeah, exactly. But it's actually kind of funny because we'll go to great lengths sometimes to bring the patient to the operating room, and we position them very carefully. We do a very careful rotation over to the back, and then the spinal surgeon will come in and kind of grab the head and go, yep, that looks great, and kind of stick it in the right position. We're like, we just spent the last hour doing some very careful movement. And then other times we'll think, oh, that injury doesn't look too bad. And the spine surgeon will come in and be like, okay, nobody move, no one breathe. I'm going to do this myself. So it's, you really can't tell sometimes. And that's why I think we all take bigger precautions until we have some word from someone who knows a lot more about this than we do. Yeah.
It's important to remember as well. Like, I mean, I've been doing this. I'm by no means a veteran or an experienced paramedic, but I've been doing this long enough that I've been absolutely caught off guard going in both directions. We've walked someone in who, was in a low mechanism event, and there's no indications they pass all their NEXUS criteria. They're kind of, they're wandering around looking all over the place. We bring them into the department. We come back 3 hours later and we see them in a collar being sent off for a CT, and someone says they had a C2 fracture or something. Oh, wait, what? And similarly, we've certainly, had patients where we treat them with kid gloves. They've got this midline pain and some numbness and tingling in one limb, and there's a significant mechanism, and all this. And they go and get imaged, and it turns out there's absolutely nothing there, that they just have a soft tissue injury, right? And so it is important. These exceptions do happen. It's good to recognize that they do happen, but it's also pretty important to stick to your protocols and guidelines. Most agencies, I think certainly St. John and certainly the other pre-hospital agencies that I'm aware of, have their protocols and guidelines in place for a reason, because they're designed to catch the vast majority of people that do have spinal injuries and have them clinically managed appropriately. So I don't know if there's any questions from the group, or if Nav, if you had anything else you wanted to expound on.
Nothing else from me. Yeah, thanks for having me back. I can either do part 2 of the talk, which need to think about how to do that, or we can talk about more different topics. Something always happy to come back and talk. Just remember, stay safe out there. COVID numbers are going up. Doesn't mean we have to lose our minds, but just keep doing the same things we're doing so far: washing your hands, wearing a mask when possible, socially and physically distancing, and we'll get through this. There's 2 vaccines on the horizon, 3rd one in the works. I think we're looking for a good summer next year.
Fantastic. I think we just had one last note from Andy and Shirley and Kamloops here, just noting that we do extrication with St. John. We do extrication and often use a clamshell to get the patient off the field of play or out of wherever they are, and we keep them on the clamshell, so we maybe have an easy way to move them over to another responding agency's stretcher, which I think is a really good point. Within St. John specifically, we're often leaving people on the clamshell until the end there. Thank you. Oh, another question here. I'll leave that one to Nav.
Sure. So questions about something called autonomic dysreflexia. That's a great question. I'll just answer that briefly, and maybe I can do that and talk more about that in part 2. But autonomic dysreflexia is something that is seen in chronic spinal cord injuries. So this usually sets in kind of weeks to months after the injury, kind of especially once the period of spinal shock has resolved. So once whatever tissue injury and swelling and everything has abated, and whatever function that the patient is left with at that time has kind of set in permanently. And there's ways that we can test this, usually relating to how the lower portion of the spinal cord, the sacral portion, is functioning. So for chronic spinal cord patients, where I was talking about how that sympathetic chain can be disrupted and then endogenous mechanisms take over, there is still that imbalance that's there. It's just that the body has compensated to what's going on. But what can happen is that if the person gets a stimulation below the level of injury, because there's no signals going up and down the spinal column, that area of the body becomes, in a way, very angry. And so a common example of this is when spinal cord injury patients may have to go and have a procedure done on their bladder, like looking in the bladder with a camera. That's very stimulating. Usually we may have to put patients to sleep for this. Sorry, we don't usually put patients to sleep for this if they're just looking in the bladder, but it can be really irritating. And what can happen is that in a normal patient who's maybe having this procedure, there's signals that come from the brain down the spinal column and tell the body, no, this is okay, and kind of turns everything down. But spinal cord injury patient, those signals kind of create a little feedback loop in the lower portion of the injured spinal column, and these start to ramp up. And what can happen is that you get a localized increase in catecholamines that can occur. This can drive the blood pressure very high and kind of feeds back on itself. There's no descending signal from the brain that can get there and starts toning that down. And this is called autonomic dysreflexia because it's an inborn reflex in the spinal column portion that's damaged that's causing this to occur. And so it's something that we see in chronic spinal cord patients. They usually know how to treat it. We can give medications to treat it, or patients can just take away the stimulus and it goes away. It's very common. We see it in a lot of anesthesia because we may have to give patients an anesthetic or inject medications to kind of dampen down that reflex. But that's something more that we see in chronic spinal cord injury patients than in acute injury. Good spelling, almost there. Dysreflexia has a Y in it. Yes, and can occur with urinary retention if it gets really bad. Basically, any kind of stimulation that can be normally irritating to a patient. So urinary retention, pain on the foot, pressure ulcers that kind of get out of control, constipation can cause it as well. And this is really where chronic spinal cord injury patients learn to recognize different signals that can occur and try to prevent this. there's kind of like this urban, I don't know if it's urban legend or urban myth, but I think it actually happens more common than we know, where special in Special Olympics, especially with spinal cord injury patients who are competing, may actually try to elicit some kind of autonomic dysreflex in the cells, because, as I said before, it's a catecholamine response, so it gets their adrenaline and noradrenaline going, and so when they try to elicit some of this in their response, it may help them compete better. To kind of like form like a natural juicing in a way, in a temporary form. But yeah, anything that's kind of irritating to the lower portion of the body. And some people in chat are saying that it's typically T4 or higher. We worry about it if it's T6. T6 or higher is usually where we start to worry about it, although it can occur at any level in the kind of thoracic sympathetic chain area, but we usually worry about it more in kind of T6 and higher. Good questions, guys.
Maybe just give it another second here for more questions to pop up here. Now, I think I'll maybe just echo everyone's thanks directed to you. We're incredibly lucky to be able to have you, available to us to give us talks like this. And certainly for myself, I always walk away feeling like I learned more than I can keep track of when I've had a chance to attend one of these or host one of these myself, Nev. So thank you for your time this evening.
No worries, guys. Always a pleasure to be here. Stay safe, and we'll see you guys in the new year. Oh, sorry, I will see you guys in the new year. We're definitely going to have more of these talks. I'll leave that to Nick.
Absolutely. You've just set yourself up now. We'll talk to you tomorrow. I'll try and hit you up for some more stuff for January, February. I think we'll call it an evening there. Thank you for everyone attending, and have a lovely evening. Stay safe out there. Take care, guys.